Thank you, Dr. Chatterjee and the whole team. I could able to see our own girl is moderating this session. I think you can sit on the stage. So I think why the crowd is less, I can count that nowadays everything is available online, and in being editor proceeding, I also keep sending so many contents to the postgraduates that makes their job much easier sitting in the college or in the house to finish off. Anyhow, I have to do my job. I thank the chairperson, my friend, for this opportunity. So I'll be talking about biometry and IOL power calculation. I believe so it's 14 minutes, 15 minutes allotted for us. So coming to the introduction, measuring various dimensions of the eye, its components and their interrelationship using a data to determine the ideal intraocular lens power. So basically biometry, it has contain two components. One is keratometry. Can you off this light please? It's hitting. Off karo. It has got two components. One is keratometry reading and axial length. Please off the light.
Switch off the LED lights.
Yeah.
And please come to the front rows.
And it has got two components. One is keratometry reading and the axial length of the eye. So probably if you look at the literature, if you see almost around 62% of the claims regarding the problem post-cataract surgery is biometric error. So you have to be dead on with your biometry. So coming to the keratometry, normally keratometry used to measure the corneal curvature, which has to be done before the axial length measurement. There are two types of keratometers we know. One is manual keratometer and auto keratometer. Even topography also, whether Placido based or elevation based topography also gives the keratometer reading. So those who are still yet to start their, we always started our career with manual keratometry. The principle is mainly it's on the fixed object and the variable image size, and the fixed image and the variable object size. So there are two companies used to produce this, Bosch and Lomb and Sears keratometer. Now coming to most of us being very much comfortable with the automated keratometer, what is the principle of this auto refractometer keratometer, which focuses the reflected corneal image from the central 3 mm zone onto an electronic photosensitive device which instantly records the size and computes the radius of curvature. So coming to the axial length measurement, you have got two types. You have got optical and also ultrasound method. So let me come to the ultrasound A-scan. Basically this ultrasound probe which has got a piezoelectric crystal that electrically emits and receives the high frequency of 10 MHz sound waves. So what it measures from the anterior corneal surface to the internal limiting membrane. If you make 1 mm error, that means it may lead to 2.5 diopters of post-operative refraction. You have to be very careful. So always errors of 50% or more always depend upon the A-scan related only. So what are the tips for accurate measurement when you're doing with the ultrasound? Always machine has to be calibrated well. Always look for a perfect velocity sitting. Always you should look for the echoes from cornea, anterior and posterior lens, and also from the retina should be present in a very good amplitude. If you ask me, average of 5 to 10 reading has to be taken, and giving the lowest standard deviation, that is ideally less than 0.006 is ideal. So sometimes misalignment along with the optic nerve is recognized by the absence of square spike also. So normally how you have to keep the gain should be set on the almost lowest level which has been for a good reading. Higher gain, better sensitivity, but the resolution always get compromised. So at low gains the sensitivity is less but the resolution is very, very good. So there are the uses of gain in difficult situations, especially you have to increase the gain when you got a dense cataract, or you should decrease the gain especially in case of silicon filled eyes or pseudophakic eyes. Coming to the immersion technique, Is it time consuming, and also, but it gives the perfect reading, can be performed in the standard ophthalmic chair, which is retained at 45 degree with the help of oceaning and Prager. So there are some, while doing this test also, there are patient may have inadequate patient fixation, especially patient with the nystagmus, blepharospasm and strabismus, even with the patient with the low vision. So one or two points about posterior staphyloма is very important. Always which can cause the irregular shape of the ocular wall. Always you should remember deepest portion of the staphyloma may be located eccentric to the macula, thus the measurement may be longer than the true axial length along the visual axis. So normally silicone oil, as I said, that you have to, low sound velocity can result in, sometime it may give the wrong reading, so you have to keep the setting much lower level. So coming to the now we are all from the ultrasound biometry, most of you are all colleagues moving on to the optical biometry. We started with, I don't have any financial interest with this product, which is the gold standard. I just wanted to discuss with you. We started with the IOL Master 500, then now we are switching over to the IOL Master 700. So basically it is the IOL Master 700, it works on the sweat source OCT. So you have to go for a biometry which is work on the sweat source OCT, which gives the full length, which is we can get the different geometrics of the eye. So this is just a comparative study between, I think we had a lens star also, which used to work on the interferometry principle, but the IOL Master 500 used to work on the partial coherence interferometry. But again, IOL Master 700, they upgraded its work on the sweat source biometry, because it does the scans almost 2000 scans per second. This is very, very important. So it scans in 0, 30, 60 and 90 and 120 and 150. So normally it looks in the different parameters. This is very important. There are 7 parameters it take a count before giving the actual reading. That is the axial length, antechamber depth, lens thickness, central column thickness, white to white and keratometry. So you have to remember that these 7 points normally take care about. And also the one more advantage of this machine, it can, the readings from there can integrate it into the cataract suite, that is the Callisto markerless system. So this is how this sweat source biometry is work. I will not talk about, but what I said, that speed is almost around 2000 scans per second. So now coming to the few, again I am just insisting, you should remember about, it takes care about the axial length, AC depth, white to white, age of the patient also, lens thickness, central corneal power and the previous refraction. So when you do the scan, always you should look for the proper foveal pit. That means the patient is having a good fixation. If there is already comes in the red, that means it is a no foveal pit, that means a poor fixation. So whatever the reading you get, which is going to be wrong only. So if you see your measurement 1 and 2, it's if you see there is a good fixation. C for the foveal pit, that means is good. Then there is axial length, there is if you see in the both the reading, it's almost same only. So that means only 10 micron difference in the two readings, that means it's done the perfect. And if you see here in the keratometry, only 0.02 diopter difference in the keratometry, that means you have taken the perfect reading, because most of the fellows PGs might have joined for some of the institute. You are the person who is going to do the biometry, so you have to be dead dot on while doing the biometry, because we all consultant depend upon what biometry you do, then rather we go ahead with the surgery. So it is very, very important. So then looking at the C's, there are certain things. If you see here, there is a poor fixation, that means there is no foveal pit here. So then if you see here, axial length, there is a difference of more than 190 micron, that means it is the wrong only. See, if you look at the keratometry also, more than 0.5 diopter difference in keratometry, that means you are not taken. If then something, when you do the value of also, you could be able to see there is a 1 difference in the calculated IOL power, that means you are not done perfectly, rather you have to, again you do it. Sometimes what you, I just wanted to tell you, some of our consultant, we do put a drop of lubricating drop sometimes if you think that the patient is having too dry eye, and you can ask the patient to sit for a half an hour or 1 hour, then you can again cross check the test, then I think you may come up with the better results. So this is about the graph. As I said that it takes the whole length of from front to back. The one more advantage of this machine, the fully integrated Barrett suit. I think mine was fixed not for 15 minutes, I believe. So they fixed for 10 minutes. And I'll just finish 1 minute only. Overall, 15 minutes was the talk. Yeah, 6 more minutes. Okay. So get fewer refractive surface fully integrated in especially Barrett suit. Especially Barrett, just to tell you, Barrett has got three formulas. One is Barrett Universal 2, which is good for all non-toric intraocular lens. Barrett Toric for all toric lenses. Barrett True K is for all non-toric, especially after laser vision correction. This you have to remember. Barrett True K for non-torics after laser vision correction. Normally, these all formulas are automatically applied depending upon the what type of IOL you selected and the refractive surgery status of the patient, which is the incorporated influence of posterior corneal surface. So this machine takes about the posterior corneal surface. And the one more advantage, if you see here, the cataract is almost too dense cataract, so it can penetrate such a dense cataract almost in a 92% of the cases. This is very, very important. So the other advantage with this nowadays, most of these sore cities, you can see some of the foveal pit also, or there is an old case of BRV you can pick up, and immediately you can refer them to your retina colleagues. Make sure that you are ready. You will give the best perfect income. Because why I am telling you, suppose if you plan for a premium surgeries. So when you plan for a premium surgeries, what happens? You tell them, I want to put a multifocal, but when you're doing biometry, being a PGs or fellows, you see that there is some problem with the macula, then we can deny them. Rather, just after the surgery, you notice them, then nowadays there is no answer to tell the patient. This is very, very important. So these are the few advantage with this. You can see even with the macular foramen also, you can see here with the, these are the few macular pucker. You can pick up RP detachment, you can pick up even with the IOL Master 700. And all four generation 4 formulas cover a broader spectrum of island. Like you can do holiday, Hoffer Q, SRKT, especially SRT in case of high hypermetropic, holiday 2 or Barrett's 2 in case of myopic. So you can select, you can compare yourself. So spend time with the biometry, you can learn more and more. Then we can have a workflow also with the different formulas which IOL to be selected. So if you see, so fast it takes, especially IOL power calculation, Hague suits for, just go to the someone like, because most of the center is having nowadays with IOL Master 700. So just go to the list, select the IOL model, and you will come up with the press calculator. Then it has got even a toric calculator also. You can see the biometry. Now what we do, normally patient comes, we do the biometry, then we send for counseling. Because if they are having astigmatism, then you counsel them for multifocal or trifocal. Without counseling for toric multifocal or toric trifocal does not make any sense. So this is about, normally if you can see how fast it takes the reading, measurement from both the eyes, which is less than 45 seconds. This is very, very important. With the results what we get is amazing. We have done even comparison study with this IOL Master 700 with the 500, also with lens star. The accuracy with these equipments are much good, and when you opt the patient, when you opt them for a femto assisted premium surgeries, always you need to be dead on as far as the biometry results are concerned. So you can see less than 45 seconds, you can get all the reading, and if you can see all parameters, white to white, everything is perfect. So we can integrate to see whatever they say. I do a lot of torics and toric multifocal, so it integrates from to the Zeiss cataract suit. So no preoperative corneal marking is required, no additional measurement of the toric IOL alignment. So there are limitations, especially positioning the patient with the mobility problems. Sometimes it may occasionally may be a problem. Even with a very dense cataract or very dense corneal scarring, you have to be little bit careful. It may be inaccurate in patients with axial or sometimes with very dense cataract, even with a very gross astigmatism. One more thing is, this is all expensive. If you want to get the best, I think you need to pay for that. So in summary, normally get a fewer refractive surprise also. You can have improve your refractive outcome, repeatability with the clinical foundation and the telecentric keratometry, and you can optimize your workflow, cataract penetration rate, onboard toric calculation, easy delineation, measurement speed, and a markerless implantation of the toric intraocular lens. So in conclusion, due diligence has to be undertaken during the biometry to prevent post-operative refractive surprises. A proper history, use of optical biometry and specific formula is utmost importance. In customization of cataract surgery, biometry is primary. I thank my friend Dr. Santosh and our whole team of AIOS for this opportunity. I thank the chairperson for opportunity. Thank you, one and all.
Thank you, Dr. Kudlu, for this comprehensive talk. And I think because he'll be leaving, we can direct any questions to him right now. So, you all are doing biometry. How many of you postgraduates are doing biometry on your own? How many of you seen a biometry being done? Two hesitant hands.
You all in which year? Third year. In the medical college, I just wanted to ask all medical colleges, do you have a optical biometry? Or you are still in the ultrasound only? Yeah, DNB Institute should have. DNB, every institute will have optical biometry. But anybody only sticking on to ultrasound? Only having experience with ultrasound? See, just to tell you about ultrasound biometry is also good, provided you have to calibrate the machine. I was just telling you about the immersion technology. But all this Prager shell or whatever the shell you do, it has to be very much sterile also, because one of the study from Arvind shows that almost lot of organisms has been grown from this Prager shell. So you have to be very, very careful. So you have to do the proper autoclaving for those shells also.
Just can I ask because they are not able to come up with the questions. Suppose you have a very irregular cornea. So what strategies do you do to get a good keratometry? Like if you have a corneal scar, you have a corneal keloid, post-corneal graft. Yeah.
Irregular cornea, sometimes just the last week itself, I had a patient with a microcornea. So I tried with IOL Master 700, it was not coming. Then what we do, we have got a gadgets of all the equipment like pentacam and other equipment. What we did, I took the patient in front of the pentacam. Still it was not coming. Then finally the as simple autorefractor keratometer could able to get the proper K1, K2. Then that K1, K2 I entered in the IOL Master. Later on it got the axial length. Sometimes this kind of thing you may not get. So you need to have other equipment. But good standard clinic should have a very good autorefractor keratometer, and along with because the autorefractor keratometer, the central 3 mm, that gives the perfect keratometry. That is more than sufficient even for doing a premium surgery like toric or multifocals.
Thank